Good evening. First, I'd like to start by saying good evening and good morning and good day to all of you around the world. It looks like we have quite an international group registered to watch this webcast. My name is Dr. Aaron Welk. This webcast is titled Finding Your Way, Navigating Root Canals Using a Cordless Multipurpose Dental Treatment Handpiece. Here, I would like to first thank Viva Learning for hosting this webinar today. I would also like to thank Marita for the development of a new product and sponsorship of this presentation. So first of all, I just wanted to point out some interesting information here, some data from the economics of endodontics from the AAE in 2001. So back in 1999, there were more than 1 billion dental services performed in the United States. Endodontic procedures accounted for 21.9 million of these services. Another way to look at this is that endodontic procedures accounted for only 1.7 of all dental services performed. So of these 21.9 million dental procedures, or endodontic procedures, 75% were done by general dentists and 4.5 million were done by endodontists. So in the United States, endodontists account for roughly 2.5% of all licensed dentists. A little bit about me. I'm from the northwest part of the United States. So right now it's 5:15 p.m. If you hear vehicles driving by, that's because I'm at my office and people are driving home for the end of the workday. My training was at the Oregon Health and Sciences University in Portland, Oregon. I've been a licensed dentist for the past 20 years. I got my specialty in endodontics in 2002 and am a diplomat of the American Board of Endodontics. I've been in clinical practice for the past 16 years. I started a practice in 2003 and have been practicing in Tualatin, Oregon, which is a suburb of the Portland metropolitan area. So first of all, I just want to do a little overview of what we're going to talk about this evening, or depending on where you're at. My plan for the webinar is first to review the history of electronic apex locator technology. I'd then like to talk a little bit about the use of cordless endodontic motors. I will review the features of the Tri-Auto ZX2. And then I'm going to just present a straightforward clinical case using a cordless electronic motor in my private practice. So as I mentioned earlier, my dental and endodontic training comes from OHSU, or Oregon Health and Sciences University in Portland, Oregon. Here's a picture of the dental school that I went to and attended. It was built in 1956 and it was up on the hill in Portland, overlooking downtown until 2013, where the dental school then was moved down to the south waterfront. You can see here a picture of that dental school there. My mentor was Craig Baumgardner. He is highly respected in the endodontic world as one of the researchers that contributed to the advancement of our understanding of the microbiotic makeup associated with infections of endodontic origin. But in addition to being a microbiologist, he was a practicing endodontist. He practiced clinically, and he was a fantastic department chair and program director at OHSU. He encouraged his residents to become familiar with the current instrumentation methods and modes of treatment available, not only to develop an understanding, but more importantly to find out what worked best in our own hands as a clinician. And it was at this time that I developed an interest in the clinical use of apex locators and the accuracy of these instruments. So this is just a couple more pictures of Portland. Let me get the cursor here. So the dental school, original dental school is here. And if we look down in this area down here, that is the new dental school down by the waterfront. Here's a view from the 13th floor. This is the endodontic department, and this is looking at downtown Portland. So a little bit about the history of apex locators. Custer was the first to introduce an electrical method of locating the apical frame back in 1918. Suzuki's discovery in 1942 that electrical resistances between the periodontal ligament and oral mucosa registered at a constant value led to the development of the first electronic apex locator by Tsunada in 1962. The accuracy of early apex locators was pretty poor because of the influences of fluids or pulp tissue found in the canal. Advancements over time led to the development of units that made accurate readings in the presence of various electrolytes. It was Kobayashi and Suda that developed the Root ZX, which is based on the ratio method for measuring canal length. The principle behind multiple frequency apex locators is based on the change in impedance of the probing electrode, which is the file, to the tissue fluids. When a file tip is located away from the minor diameter, the impedance in the canal is negligible. But when that file reaches the vicinity of the minor diameter, the magnitude of the impedance of the canal suddenly increases. And then as the file advances beyond and touches the periapical tissue, this impedance value rapidly decreases, indicating that we've gone on the minor diameter. So the Root ZX uses two frequencies to simultaneously measure the impedances into the canal. This device determines the quotient value by dividing the impedance values. And then the minor diameter is located when the quotient value equals 0.67. So different types of fluids in the canal will give different impedance values, but by using two frequencies, the Root ZX can be used in all types of fluids because the quotient value is always the same. And I think most modern apex locators work on this premise. I'm just going to show a list of early literature supporting guidelines for establishing an ideal working length during root canal treatment. So Cutler's research showed establishing the length of the root canal system at the apical constriction was an ideal working length for endodontic treatment. Riccucci and Langland determined that this constriction is the narrowest part of the canal with the smallest diameter blood supply, therefore creating the smallest wound site in the best healing condition. This landmark can also be called the minor diameter of the canal. So the minor diameter represents the transition between the pulp tissue and the periodontal tissue. And microscopic studies have shown the distance in the minor diameter to be a range of 0.5 to 1 millimeter from the external foramen or major diameter of the root surface. So what are we exactly measuring here? And if we look at this basic diagram, to point out the minor diameter would be located in this position, whereas the major diameter would be located here. So the literature has shown that most modern apex locators are finding this area predictably. I like to think of the root canal endpoint as a target zone. There's not an exact finish line that we're measuring with these devices. So there were a series of studies done at OHSU, beginning with a study that I did in 2002. And all of these studies confirmed the accuracy of the Root ZX and the Root ZX2 in clinical conditions. Here's a slide that shows a cutback of the apex in the position of the file relative to the minor diameter that was utilized. This is something that I did during my research project. So as you can see, there's a 15 magnification and 30 magnification. The picture on the right, there are multiple constriction points present. And I'll point those out here, 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 and then the file here. So sometimes this may be why the apex layer can act erratically when in a canal. Sometimes it has a difficult time figuring out exactly where it is. But I would have to say that this is rare. I mean, apex locators are accurate probably more than 90% of the time. But there's still a place for taking working radiographs in some cases. Nothing can replace clinical experience and judgment. So if something seems off, it's best to utilize multiple methods, like utilizing your apex locator, taking radiographs, maybe even using paper points to drive the canal and making a working length determination. Cordless handpieces have been used for endodontic treatment more than 20 years now. There are many studies that show the benefits of using continuous monitoring of working length during root canal instrumentation. Continuous monitoring of the working length is important because the length can vary during the procedure, especially with curved canals. In addition to the length measurement function, these handpieces also have torque control and speed settings, and we'll talk more about that later. There are a number of apex locators that are integrated into handpieces out on the market, and here's just a few just to show some representation of what. I'd say 15 to 20 years ago, it seemed like there was an exponential growth curve of emerging endodontic products out on the market. And these electric motors and handpieces were part of this product explosion. So one of the frustrating parts for me performing endodontic procedures was dealing with these handpieces that were quite heavy, and also with the cord they were tethered to the base motor sitting somewhere in the operatory. I'm sure you've all experienced times where you needed to stop doing a procedure, make an adjustment with your body position, adjust the delivery system, or even have the patient move in order to get your handpiece to reach. So just before I finished my residency in 2002, I discovered and started using cordless handpieces. I realized that a cordless handpiece would give me the freedom to treat patients without restriction. So as an operator, this was very comfortable for me to be able to hold this lightweight handpiece and not be tethered to a base, and it allowed me to be just more efficient in the operatory. So here's a picture of me sitting in a position working on a patient. Another angle showing the view. This next picture, and so this is kind of just the standard. You can use this for holding and positioning in most of the mouth, except for on the left side. It can sometimes be difficult to position a file to gain access into canals. So specifically, when we're working on upper molars, left side, maxillary molars on the distal buccal canal, sometimes it's hard to get that file in the right alignment to follow that pathway. Or even today when I was working on a lower mandibular molar, to get on the left side, to get into the mesiobuccal canal. Sometimes you have to take the handpiece, and if you look here, it's actually, I call this handpiece inversion, but I have it flipped over so that I can get into position. So if you pictured a cord tethered here and connected to the cart over here, or even connected back here at the 12 o'clock position, it would be sometimes difficult to get that to work without pulling all of your equipment around. So the cordless handpiece really gives you the freedom to not have to worry about that. So my first venture using cordless handpieces was an early generation NSK handpiece called the Endo Mate torque control handpiece. And this handpiece worked well for many years for me. It had a simple on-off button. It had variable speed settings. I think the speed settings went from 100 RPMs up to 625 RPMs, or from like 150 RPMs to 1,000 RPMs, depending on the reduction angle that was used on the handpiece. You could adjust torque control, and it had nickel metal hydride batteries that would easily hold a charge for a week without loss of power. So, I mean, basically I would charge this every week. I would do 5 to 7 cases and not have any worry about the batteries dying. And when they did die, you could easily replace them. And contra angle here came in either a push button or a latch style. Now, I preferred the latch style because the push button was very difficult to press when working. There are different ways to exchange files during the procedure, and I'm going to show you the way that I do it. I like to keep one handpiece and one contra angle and just have the files change out instead of the handpieces changing out. So the latch contra angle made a smooth file exchange with me and my assistant. Here's the next handpiece that I used was the also an NSK handpiece. The first one was the Endo Mate. This was called the Endo Touch. Vibron Endo product, or Kerr Endodontics now. But this handpiece worked well. I used both of these versions of this handpiece for 13 plus years. Eventually they would fail, and what would happen is the plastic connector, and there's a metal ring here, that would start to loosen. This would start to break down, and it would start to kind of swivel here, or the button would wear out. But in general, this handpiece worked really well. It was a real basic handpiece, but got the job. I was really excited to switch to the Brasseler EndoSync handpiece. This was the first handpiece. I think it was late 2016 in the U.S. market, and it came out and it had OTR technology. So the OTR stands for Optimum Torque Reverse. We'll talk a little bit more about that later. I was really excited because of the way that the OTR functioned. I had some issues, technical issues with this handpiece. The on-off button was not working predictably, and it would stop working, and handpiece stability issues, but I'm sure they've improved it since it was first released. That's always one of the things to be an early adopter of technology. Sometimes there's glitches that need to be worked out, but in general, I mean, this did a nice job. So regarding optimum torque reverse, here's a study that shows that actually was in the International Endodontic Journal, and it evaluated the influence of optimum torque reverse on cyclic fatigue of NiTi files. And the optimum torque reverse motion significantly improved cyclic fatigue resistance compared with continuous rotation. Peters and Barbacow here demonstrated the influences of torque on file separation, and cyclic and torsional fatigue are two main factors that lead to file failure. So torque control handpieces provide some feedback to the clinician when these conditions are encountered. Having trained in dental school using hand files and switching over to rotary files, this was right at the inception of rotary endodontics. One of the complaints was that when you use a rotary handpiece, you lose that touch, and I'd have to disagree with that. I think that you just develop a different touch, and you want as much feedback as you can get. So lighter handpieces give you some feedback. This optimum torque reverse gives you feedback, and we're going to talk about some other features that give you feedback. But it's an amazing time with technology is allowing us to almost automate this process, or give you different levels of automation that make this a more efficient and safer way to do endodontic procedures. One thing I want to point out is that there's definitely observational bias in this presentation. So the majority of the items presented here are things that I've used clinically, and I'm just presenting my use of a cordless electric handpiece in the treatment of patients undergoing endodontic procedures in my practice. So to talk a little bit about the Merida Triado ZX, this came out, I believe it was released in midwinter Chicago 2018. I was able to get my hands on it from my local rep shortly after that, and purchased two of them at the American Association of Endodontists meeting in Denver last April. And I actually approached Merida and offered to speak about the benefits of this handpiece because I was so excited about how wonderful this thing performs in my hands, and I think it would perform excellent in anybody's hands. I think that this handpiece is probably at this point the most complete and comprehensive rotary handpiece on the market today. And here are just a few of the features here. So I mean, there are three main modes. There's a built-in electronic apex locator function. There's a feature called Optimum Glide Path, and this allows you to create glide paths and achieve patency in the canals. And then the Optimum Torque Reverse technology helps minimize the risk of file separation in the canal. So there are 8 pre-programmed settings on this handpiece. Here's just an overview of each of these program settings. Most of your procedures can be done using the first 4 settings. So the M1 setting is the apex locator function. M2 is the clockwise rotary function, and then we have the glide path and the torque reverse. And I'll talk more about these in a moment. The remaining settings are similar functions that are just set up a little differently for more complex canals. And the last function, the M8, is a counterclockwise rotation that allows you to inject solutions into the canal, like calcium hydroxide using, say, a lentulo spiral. So with this first mode, the EMR mode, or electric measurement of the root canal length, this is your apex locator. So it can be used as a standalone apex locator, and it can also be used with the handpiece to measure the canal length in a real-time feature. Here's just some displays of the handpiece here. So over here on the left, we can see M1 is just memory 1. You can see that there's a reading like most apex locators have. The 3, the 2, and the 1 really don't represent anything as far as distance. They just kind of give you a sense of distance, but they're not telling you that you're 3 millimeters, 2 millimeters, or 1 millimeter. There's a box here that is a flashing bar, and actually this is the flashing bar as well over here. So, you know, when you advance it, you're advancing to roughly, you know, half a millimeter from the apical constriction or the minor diameter. And this is adjustable, so for those of you that feel more comfortable having it be more at the 1 area, you can actually adjust it between the AP and the 1 setting here. I just wanted to show you a short video of how this would look if you were using this connected. So here this handpiece is connected to, and it's just kind of looping around and kind of hanging over here. It's not actually connected to the card at all. It's connected to the patient's lip with the lip clip, but I'm going to use this in a function where it's telling me the working length real time here. So there you can see the display. It's set with M1, and then I'm advancing the file into the canal. There's no sound with this, but you would be hearing a beeping sound, and you would be able to be looking at the display here on the handpiece. The nice thing about this handpiece is the contra angle can be swiveled 270 degrees, so you can change that handpiece depending on the position of the tooth and how you want to hold the handpiece. So the next mode is the CW mode, or clockwise rotation. So I mean, this is just your standard electric handpiece rotation. There's no, you know, you can set it with torque reverse, or you can just say reverseless here. I use this for my gate squid drills, so it can be used for any shaping, coronal shaping file. And you know, for me, this M2 feature is perfect. It's set at 600 revolutions per minute, and it works in a clockwise manner. So instead of using your gauge splittings in a traditional slow-speed handpiece that may operate in the range of 5,000 to 10,000 RPMs, you can use it at 600 RPMs. And this actually reduces the risk of canal transportation or stripping of the canal wall. So the gates, personally, I use the gate splitting 2, 3, and 4 for shaping the coronal 1/3 of most canals. And by removing this coronal debris, it allows my NiTi files to work under less strain in the apical and middle thirds of the canal. Here's a video, once again, showing and demonstrating the use of this with this handpiece. So I'm actually, with my index finger here, I'm pressing the button and activating the handpiece. So this button is very responsive. It works like a rheostat. When I apply pressure to it, the handpiece is on. When I let up, the handpiece stops. You can also activate it by pushing it and removing your finger, and it will stay in the on position, and pushing it and releasing it to turn it off as well. But when I'm using it, if I'm not using this handpiece in its auto mode, I'm actually just using it like it's a finger rheostat, basically. So the optimum glide path is I think this is a new feature that's on the Triado ZX that most handpieces do not have. So with a glide path, you know, first of all, I guess just to define here, the glide path is having a smooth pathway from the canal orifice to the apical foramen. So it's really important when you're using rotary instrumentation to establish a glide path. I mean, this is also part of establishing canal patency. So without a glide path, rotary instrumentation really shouldn't be attempted. So establishing the glide path is commonly done with hand files, but this can be difficult and fatiguing depending on the tooth, and it's time consuming. So, you know, once again, we use rotary handpieces to do a certain job, but one of the jobs that they do is they make the procedure more efficient. So that's that is one of the nice things about this optimum glide path feature from the Root ZX2, is it makes it a very efficient step in the root canal process. I just want to define reciprocation. So, here it says reciprocation is an alternating motion. So I'm just describing or defining a motion. I know that there are files on the market that are considered reciprocating files. I'm not talking about that type of instrument in this handpiece. I'm just talking about the motion of reciprocating, going back and forth. So with the optimum glide path, the glide path works. The motion is a reciprocating motion. In endodontics, we also call this a watch winding or balanced force motion. So the optimum glide path can accommodate files that are smaller than a size 20. So I use path files. That is a Dentsply product. You can use Manny files. You can use Scout files. So basically, any of these files that are an O2 taper file from a size 10 to a size 20 work really well in this mode. So the motor reproduces the watch winding and balanced force motion. So for example, here's 3 different mode options that you can set. So at the 180 mode, what's going to happen is this handpiece is going to rotate forward 180 degrees and then 180 degrees in reverse. And then it's going to rotate 180 degrees forward and 270 in reverse. And then it's going to go back and it's going to repeat that, 180, 180, 180, 270. So it's kind of doing this reciprocating motion to safely and efficiently follow the pathway, even in curved or constricted canals. Here's a video from Marita demonstrating the glide path motion. It's a little fuzzy here. Hopefully you guys are seeing this okay. If you watch the apex of the file, of the root, you'll see the file go right down to the end. So patency's been established. And then here's just using this clinically. Once again, I still have it connected because I'm using it in an auto feature here, and we'll talk later. Okay, so another mode is the optimum torque reverse. This is basically your cleaning and shaping mode. This can be used with your preferred file system in this handpiece. So under normal conditions, what happens is the motor operates in a continuous forward motion, forward rotation. But when the torque is increased, this optimum torque reverse works in an alternating forward. It goes in a forward motion and then back 90 degrees, and then it goes, so in this situation it'll go forward 180, back 90, forward 180, back 90. I almost want to call it a ratcheting motion. But what this does is when the file starts to encounter increased torque, it's going to continue to work, but it's going to do this forward and back motion to prevent file jamming and or separation of a file. This creates a safer environment when you're doing this. And as an endodontist, I mean, I want to be as efficient as possible. And I was efficient with my EndoMate handpiece. I am doubly efficient with this type of optimized torque reverse. Optimum torque reverse really makes this an efficient procedure. Here's a video also showing this. So if you watch the rubber stopper, you'll see it kind of go back and forth, kind of showing you working. And I think there's a lot of pressure being applied to this X3 file here, but it's pretty neat to see it kind of ratchet back and forth here. And then once again, from a clinical view, at this point I'm using this in manual mode here. I'm using my finger to actually I'm using my thumb to activate because I have the contrary angle rotated, and my thumb here is actually pressing the button to control. And then lastly, there's a counterclockwise rotation, like I mentioned earlier. That's used if you want to put a paste material into the canal with a lentulo spiral. This works in a double beep sound. It continuously beeps, kind of like a vehicle backing up to let you know that you're going backwards here. So there are many additional settings of the Triota ZX. Just to show a few here, and we can talk about these a little bit here. But I mean, there's an auto start and an auto stop feature. So when the file will start rotating when it's placed in the canal, and it'll stop when the file is taken out of the canal. This is when it's connected to the sensor. The lip clip is attached to the patient. You can adjust the action of the motor when the file tip reaches the endpoint. So that's, we call that, I mean, they call that apical action. The flash bar position can be adjusted so that you can set it from anywhere from 2 to the apex on the meter. You can use the apical slowdown, so the rotation of the file will slow down as it approaches the apex. Torque slowdown also reduces the torque as it's the load is increased on the file. And then the apical torque down, the torque limit decreases as it approaches the apex as well. So a couple of these features, like the automatic stop feature. So when the Triota ZX is connected to the canal measurement function here, the position of the file tip is shown on the display. So in this case, you can see the file is not at the apex, and you're getting a real-time display of the root canal measurement. That's what RCM stands for. There's an audible sound that you're going to hear as well. And then when the file reaches the apex, the rotation stops and it slightly reverses. So with these, you basically are in auto mode with your instrumentation. This is great for straightforward cases. Sometimes it can be challenging when you're working on, like I said, as an endodontist. It's sometimes difficult when you're working on second molars, limited openings through lots of metal crowns and things like that. That can be a little challenging. But in general, for many cases, most of the straightforward cases, you can use this auto feature. Optimum apical stop. With this feature, the file will stop and reverse slightly when it gets to the endpoint. So this once again just reduces the risk of that file from jamming in the canal. And like most handpieces out on the market, there are various speed settings. So this handpiece has speeds from 100 to 1,000 RPMs. It's got torque levels that can be set from 0.2 Newton centimeters up to 5, depending on the mode that you're in. I'm just going to present a straightforward case here using a cordless multi-purpose handpiece. So in this case, this is an upper left maxillary second molar. Tooth number 15 is what I would call it. History of a lithium disilicate or an EMAX crown that was placed a year ago. The crown was replaced because the previous PFM crown had fractured. But since the crown was replaced, the tooth has had hot and cold sensitivity, lingering pain, and the patient has she reports headaches. So here's a pre-op film showing the tooth. You can see the first molar has already had endodontic treatment. Let me show you. So I'm just going to go stepwise just through a few. Hopefully you'll find this interesting. I don't see this on many presentations, and sometimes I think people would like to just see the clinical aspect of things here. But this is just through the microscope. Whoops, let me go back here. So, access is made through this crown using a diamond burr. This is actually a coarse diamond. I would recommend using not a coarse, but actually I've switched over to fine diamonds. Have done a much better job. One thing I'm finding with the zirconia and lithium disilicate crowns on the market is it's putting a lot more stress and strain on hand pieces. And so my turbans are wearing out, my burrs are wearing out. Well, the burrs are single use, but the fine diamonds seem to do a little better job with getting through these materials. Next step is just navigating and locating the canals, I should say. So this is kind of a, like I said, it's a straightforward case. I mean, this is a second molar that actually has two canals. So this is an easy second molar. So once we've explored and located and identified those, you know, we're going to do some initial kind of like establishing the crown down motion here. So what I'm doing here is I'm using a taper file here. This is a Dentsply Pro Taper S1. Kind of getting a sense for like how the pathway, kind of the pathway of the file into the canal is, and with this, because these are fairly large canals, the files go in with not a whole lot of difficulty. Next step is using the gauge glidens here. Once again, these are not working very hard in this tooth, but I like to still make sure that we've got smooth transition in the coronal portion of the root canal system. So every time the handpiece disappears, it's just getting exchanged out with a different size. That was a 2 gates, this is a 4 gates, and then I go a 3 gates and a 2 gates. So at this point, you know, this is when working length is established. So here I'm using this in an automatic mode here. I'm advancing the file down. I'm looking at the display, and I'm making sure that I'm where I want to be. I'm not using rubber stoppers because I'm looking at the microscope, and and this is once again the mode from the top here, looking at the display. I'm using the markings on the files to determine length based on a reference point on the crown. And of course, we irrigate, and irrigate more. I use sodium hypochlorite. And we irrigate and we shape the canal. So this is in the PR mode. Taking out a file here and then going to work. This camera is showing the distance. It's actually, because it's only showing through one of the eyepieces here, it seems a little bit off, but when you're looking at it in stereo, it's a lot easier to look down inside the canals here. And then once again, here's a bird's eye view. I'm going to show another video of this file exchange, but I mean, I like to just do a quick file exchange. This button is so effortless to press. I can just reach up with my finger, I can press the button, my assistant can pull the file out, put a new file in, there's a little clutch that just locks it in, it's ready to go. So it's a quick change. I don't have to hand over the handpiece, get a new handpiece, everything stays in one place. Okay, so change out here. And with this tooth, I'm just about done cleaning and shaping because whoops, more irrigation. So, I mean, I'm using sodium hypochlorite and I'm using EDTA with a final sodium hypochlorite rinse here. And the canals are dried. May be boring for some people to look at, but a necessary step. Canals are dried. Do a warm vertical compaction. Can be obtura. Here's a down pack. Got done with this fill. Let's go to the next. And then the tooth was restored with a composite restoration. I see some people are having problems with the sound. I apologize. I don't have a lot of control over that. Okay, so pre-op film is on the top, and then here's a post-op and an angled post-op. There was one question about, with a very necrotic canal, do you fill after filling the canal? Do I? I'm not sure I understand that question. Here's a CT as well. And then I wanted to show you once again just the handoff here. I mean, I think that this is probably the most This is something that I think is easy to train an assistant to do, is just without doing the method of handing different hand pieces over. File exchange can be a real smooth and easy process with these hand pieces. Easy to push a button. Okay. Any questions? All right, I don't see any questions on the board. Okay, well, thank you for spending the time to watch this, and I hope you all have a great evening, morning, or afternoon, wherever you're at.